So we'll straight away go for the talk. I'll try to make it as simple as possible. It's quite a complex topic, but it's an important topic. So just keep your eyes and ears open, sharp. I'll try to simplify as much as possible. EEG in an acute setting is a completely different ball game as to what you said. So basically, when there is an acute insult to the brain, whatever be the insult, the brain reacts in certain ways, which is manifest on the EEG as some of these patterns, which are periodic discharges, could be manifest as triphasic waves. You can get electrographic seizures, and you may get subtle convulsive seizures, which you may miss. There may be very minor kind of movements, which you may not suspect them to be seizures, but only the EEG will tell you that, okay, there is an electrographic component to this subtle abnormality. So that is what it is, and that can continue for a long time, and therefore you call it as a subtle convulsive status epilepticus. You have non-convulsive status epilepticus where there's any clinical manifestation, or you can get some kind of subtle convulsive seizure. So now, that's what we are going to discuss, these points, these periodic discharges, rhythmic delta activity, triphasic waves, and non-convulsive. And I'm going to use the American Clinical Neurophysiological Society classification, which is actually the latest one. The nomenclature is that. So it's no longer called PLEDs and all that. It's no longer called GPDs and all that. So now, this is the pattern that they are classified or described, not classified, they are described in two major descriptions, which is term one, which basically is the localization of a pattern. Number two is what exactly is the pattern. So let us now look at the term one. The term one is, what is that kind of localization? Localization means, okay, the pattern can be generalized. The pattern can be localized. The pattern may be bilateral but independent of each other. The pattern can be multifocal. And within a hemisphere, it can be independent. There can be two independent foci. So that's what is called unilateral independent. So these are the patterns. So the localization is the term one. The term two is actually, what is the pattern? So you have periodic discharges, you have rhythmic delta activity. These are the three main things. So periodic discharges, rhythmic delta activity, and what we classically see as polyspike sharp wave activity, which is quite common for us. So these are the three patterns, and the localization are four types. So that is how it is classified. Now let us look at how these patterns look. So let us look at that. Periodic discharges. That is how a periodic discharge will look. That means there are discharges, but there is a distinct interval between two discharges. So that is a very important point. There must be an interval. And that interval must be relatively static. Relatively static. Then you have rhythmic delta activity. In rhythmic delta activity, there is no inter-discharge interval. That is what it is. So it is continuous. So that's another one. And then finally you have spike wave discharges. This is very familiar to all of us. Again, it's a spike and wave, but there is no inter-discharge interval. So the periodic discharge is the only one where there is a clear-cut inter-discharge interval. So that's so there are various different types. You see, this is a complex rhythmic delta activity. See, it's complex means there are multiple, there is basically a delta activity, but there is also other activities which are superimposed on the delta. So that is a complex rhythmic delta. This is a sinusoidal delta, or you can have an RC form delta. So that's what it is. Now that's what is important. You can see that there must be an inter-discharge interval, and from the beginning of one discharge to the beginning of the next discharge is called the cycle. So 1 cycle, 2 cycles, 3 cycles, like that. So that is what is called a cycle. Cycle is between 2 discharges. The interval is the beginning of one discharge to the beginning of the next discharge is called a cycle. The inter-discharge interval is the one between the end of the discharge of one discharge and the beginning of another discharge. So that is the inter-discharge interval. So that is what it is. Now that's a spike wave pattern, and in spike wave, one spike is followed by a wave. So there is a consistent pattern, which is a spike will be followed by a slow wave. So that is what is a spike wave. Now let us see, okay, so this is how a generalized periodic discharge will look. See, that's what it is. So that means they are all synchronous on both hemispheres. When they are synchronous on both hemispheres, this is a sharp wave. So it's a generalized periodic discharge, right? So this is a very nice example of a generalized periodic discharge. You can see that. They are generalized because they are seen in all channels. They are synchronous across both hemispheres, and there is a almost consistent inter-discharge interval. So this is a classical example of a generalized periodic discharge, sharp wave discharge. Now, here you can see that this is a lateralized periodic discharge, because the other hemisphere is normal. Only on one hemisphere there is a inter-discharge interval which is maintained, and so therefore this is a good example of that. You can see that there is an inter-discharge interval, but it is confined to one hemisphere. So LPD, earlier it used to be called periodic lateralized epileptiform discharge, now it is called just LPDs. Now, you can have sometimes just sharpened waves with slow waves. So that, but again, important point here is that this is also a lateralized periodic discharge. They are kind of a sharpened slow wave, but there is a clear-cut inter-discharge interval. Now, this is again, you see, every periodicity doesn't have to be sharp wave. You can have delta waves. So this is LPD, lateralized periodic discharge, but it is not sharp wave, it is delta wave. Again, you have a very nice inter-discharge interval. So that's an important point. Now here, generalized rhythmic delta activity, but here you can see that there is no inter-discharge interval. This is a very important point here. You can see that this is a generalized because it's throughout, and this is a generalized rhythmic discharge, but there is no inter-discharge interval. So this is called generalized rhythmic delta activity. Now, you can have a lateralized rhythmic delta activity. Now, this is just confined to the anterior temporal which is called TIRDA, temporal intermittent rhythmic delta activity. But the point here is that this is a pattern. You can see that there is no interval between the two delta waves. So therefore, this is called LRDA, or lateralized rhythmic delta activity. So you saw generalized rhythmic delta activity, now you've seen lateralized. Now this is again another good example of a lateralized delta activity. What do you mean by bilateral independent? So that means both hemispheres are involved, but they are not synchronous. One hemisphere has got a particular pattern and a rhythmicity, the other hemisphere has got another rhythmicity. They are not synchronized. So that is what is called a bilateral independent discharge. And this is a good example of a unilateral independent discharge. So on one hemisphere, you have two different sets of periodic discharges happening. So that is how it is. In multifocal, both hemispheres are involved, but they're all completely asynchronous. So on one hemisphere, you have two independent discharges going on, periodic discharges. On another hemisphere, another type of periodic discharge is going on. So that is what is called multifocal. So it's quite clear now. So this is how it is classified. So that's a very nice bilateral independent periodic discharges, BIPD, and this is an example of a bilateral independent. We just saw one in one of the demonstrations that we saw. So this is a periodic discharge on one hemisphere. The occipital is going on, the other hemisphere is another pattern which is going on. So this is bilateral independent. And that's a unilateral independent. And this is a multifocal. On one hemisphere, there are two foci, another hemisphere, there's one focus. Now, having said that, now you have some modifiers. The modifiers are, you have to describe, once you have determined the pattern and the localization, then you have to have this, what is its frequency, what is its duration, what is its prevalence, what are the phases, all that. And then finally you have this, is it evolving or not? And finally you have what is called a plus. And what is this plus? That means there's a pattern, there is a localization, but there is, in addition to that, there is something else. Now, let us see what is the prevalence. So, how long is this pattern prevalent in a particular recording? So, you call it, if it is lasting for almost more than 90% of the record, you call it continuous. And if it is less than 1%, you call it rare. So, you can have a pattern which may last only for a short duration during a recording. So, that is how it is done. And then the duration of a particular pattern, very long to very brief. So, very importantly, if it is lasting for more than 1 hour, it is called long. Lasting for less than 10 seconds, it is called very brief. And brief. Now, that's a plus modifier. Now, let us look at what are the pluses. So, you have a periodic discharge plus fast. So, then you may have a sharp wave. On top of the sharp wave, you may have fast activity. So, that is what is called plus F. Now, or you may have plus some rhythmic activity. Right? So, plus R. Plus S. That means on a delta activity, you may have a spike. Then you may ask, we'll come to that a little later on, but that's important. You may have fast and rhythmic. And you may have fast plus spike. So, let us look at some of the examples. So, very nice. Yeah, that's a good example of, see, that's a sharp waves which are going on periodically. On top of it, superimposed are these fast activity. So, that is a PD plus F. So, that's what it is. But this is not plus F because, you know, this fast is going on all the time. So, that is not a plus F. It should be one-to-one relationship between the periodic activity and the fast activity should be one-to-one. Now, what is the difference between spike wave and RDA plus R? You get the PDs plus R. That is what it is. So, a spike and a wave, we said that there is a constant relationship between the spike and the slow wave. So, this is not plus. This is only just spike. Whereas, this is a discharge which is going on, the rhythmic delta activity, on top of it, but not consistently. There is no consistent one-to-one relationship, but then you have these spikes which may fall either just before this delta, on the top of the delta, or at the end of the delta, whatever it is. So, there is no consistent relationship. That is why it's called PD plus R. So, that is how it is. So, that is a rhythmic activity, superimposed fast. So, LPD plus F, LPD plus R. So, that's a good example of an LPD plus R plus F, fast activity. And the importance of that is, if you see this plus R or a plus F, the chances of that person developing a clinical seizure or electrographic seizure is much higher, rather than just having LPD alone. So, that's a very important point. So, that is a bilateral independent PD plus fast, superimposed fast activity which you can get. Again, you know, when you see fast activity superimposed on a periodic pattern, the chances of having clinical or electrographic seizure is very high. So, that's an important point. Now, that's a good example of a rhythmic delta activity with superimposed sharp waves. So, LRDA plus S. And you can have periodic discharges, but on top of it, you can have rhythmic delta activity, LPD plus R. So, these are all the pluses that you have. That's very important. So, that's exactly what I was going to tell. Now, we come to an important point. What is a extreme delta brush? Because that's, so it is nothing but on a rhythmic delta activity, there is consistently fast activity which is superimposed. For every delta activity, there should be a fast activity, not intermittent. So that's important. So for example, this is a good example of that. See, this is a rhythmic delta, and for every rhythmic delta, there is a rhythmic fast which is going on. This is not, because only 2 or 3 of them have got rhythmic fast activity. So this is not extreme delta brush. So extreme delta brush must have, every delta wave must be accompanied by the fast activity. So that's a very important point. So if the fast activity is there all the time, then that means the background itself is fast. On top of it, you're seeing rhythmic delta. That is not extreme delta brush. So the extreme delta brush has intermittent delta fast activity on the delta. That is a very important part. So that's generalized periodic discharges with rhythmic delta activity. Now, a pattern can have, it can evolve, it can fluctuate, or it can remain the same. So that is what it is. So fluctuation in terms of frequency, in terms of location, and in terms of morphology. See, for example, frequency means number of cycles per second. So you can see that, so this is evolution in frequency. For example, the first change is, from 5 hertz, it has slowed down to 3 hertz. So that is the first change. The second change is, you can see that from 3 hertz, it has become 2 hertz. So this is called evolution of frequency. So that is an important point. This is evolution in location. See, for this is the first location, FE1, F3, F3, C3. Then it has now gone to the next location. So it has spread over here. And then the third one, it has gone further. So that means it is evolving. Evolution is a very important part of your description of a periodic discharge. So this is a evolution of location. See, first one location, then it has spread to another location, then it has spread to the opposite side also. So that is called evolution of location. And it can fluctuate. So this is called fluctuation in frequency. So the first change, second change, third change, and so on and so forth. So you can have different kinds of evolutions, and evolution is a very important evolution in frequency, fluctuation in frequency. That means this rhythm is unstable, and that is an important component to produce a clinical event or an electroclinical event. So that's a fluctuating LPD. See, you can see that it keeps fluctuating in frequency and fluctuation in location. Again, the same thing. You can see that. So for 1 change, 2 change, 3 change. So there is a constant fluctuation in this periodic discharges. It's a good example. One of our patients, you can see that this is one frequency which is going on. Location. Okay, so that it is located in the right hemisphere. So that's very clear. The parasagittal lead and the midline lead. Now, it has now become evolution of, there's a fluctuation in frequency, there is a fluctuation in location. It has now spread to involve the right posterior cortex. So frequency is different, location is different, so there is a fluctuation. Again, you can see that it has become even faster now, and then it has involved more. So that is a classical example of fluctuation in both frequency as well as in location. And you can see that's very nice. You can see the frequency and location are changing. Yeah. Now, sometimes, in an acute situation in the ICU, when the nurses are trying to, handle the patient, for example, doing suctioning or something like that, that's a stimulus that is produced. And during that stimulus, you can get sometimes this kind of a rhythmic activity, which is called a SERPED, or a stimulus-induced seizure. So that's what can happen. So this is what is called a SERPED. Now, this is a good example of a short interval. Interburst interval is short bursts of activity. This is and this is generalized because they synchronize across both hemispheres. So this is a short interval GPD. What is the clinical significance of this pattern? You will get this kind of discharge. You see that they're very sick, and they get these myoclonic jerks. That's a very bad prognostic sign. When you see an EEG like that, it is invariably a catastrophic event. It's a post-cardiac arrest myoclonus with this pattern of a GPD, short interval GPD, not good news. Now, you can see that there's a good background activity and there is one single burst. Then you see that during this single burst, what is that? It's a slow myoclonus, generalized. But you saw only one discharge. This is a long interval. So to look at the periodicity of a long interval, you will have to compress the page. You have to bring in more and more number of, so you make the 66 seconds per page, then you will see the periodicity. So you can see that this is a periodic long interval. So you saw a periodic short interval, periodic long interval. Now you come to the triphasic morphology. The triphasic morphology is nothing but 3 phases. The first phase is always upgoing, is electronegative, surface negative. That means it goes up. The second phase is the dominant one, which goes down, which is positive. And then again it reaches the baseline, and then it overshoots the baseline, again becoming negative. And then it reaches again baseline. So first negative, second deepest positive, and the third one is again negative. So negative, positive being the largest. So that's why it becomes like some kind of a map of peninsular India. That is Gujarat, this is South India, and that is the Bengal. That's the kind of thing. And interestingly, that the duration of each of these phases, the 3 phases, progressively increases. The first phase is the shortest phase, the shortest duration. The second phase has got longer than that. The third phase is the longest duration. So that's what it is. So that's a triphasic morphology, triphasic sharp waves. So you can see in this, you can see very nice triphasic sharp waves which are going on. Yeah, so that is a very nice triphasic morphology which is there. You may get what is called the fronto-occipital delay a little bit. So that is a generalized triphasic morphology. Now a very important component we are coming to, electrographic and electroclinical seizures. So an electrographic seizure, to call it an electrographic seizure, very important. I think this is a very, very important slide. There should be, that pattern should last for at least 10 seconds, to call it an electrographic seizure. 10 seconds. In that 10 seconds, there must be at least 25 discharges. That means it should be more than 2.5 hertz. 2.5 hertz or more, lasting for more than 10 seconds is called an electrographic seizure. That is all. That is the most important thing. Now, status epilepticus, electrographic status epilepticus, there's no clinical, but if it lasts for 10 minutes, then you call it a status epilepticus, electrographic status epilepticus. So 10 seconds is a seizure, 10 minutes is a, right? Or in a 1 hour recording, at least 20% of that means 12 minutes. So that's what it is. So, and if it is accompanied by some subtle clinical, then you call it an electroclinical seizure. And then you have obviously it's basically a electrical status epilepticus and electroclinical status epilepticus, where the duration should be not more than 5 minutes. A non-convulsive can have up to 10 minutes to call it a status, but not convulsive. Convulsive is only 5 minutes. This is how an electrographic seizure should be. 2.5 hertz or more. That means in a 10-second epoch, you must have more than 25 discharges, at least 25 discharges. That is how it will be. And so that is an electrographic seizure. So this is how it will be. So, yeah. And then the other thing, it should not be just monomorphic, same morpho. There should be an incremental onset, evolution in pattern, changes of frequency, and then there will be a decremental pattern. So it's always dynamic. Then only you call it as a, okay, so now what is this? Diffuse, that means it's generalized, and you see these It's almost, some are like a triphasic, but they're basically, they're sharp waves. You just count how much is it per second. 1, 2, 3. So it's more than 2.5 and it's more than 10 seconds. So this is a good example of a electrographic seizure of what? Generalized electrographic seizure. It's not focal, right? So that is a very good one. And you see that this person, that person is actually an electrographic seizure. She's actually conscious. Conscious means she is not completely unconscious. She is reactive, but her reaction time is slow. If you do not have the EEG, you will never make a diagnosis of electrographic seizure going on. And if this electrographic seizure is lasting for 10 seconds, 10 minutes, then you call it a electrographic status epilepticus. And that's what she had, because it was going on for some half an hour, right? So that's what it is. And so that is how it is looking. So more than 2.5 hertz and more than 10 seconds is an electrographic seizure. You see, after midazolam, what has happened? There is a normalization of the EEG. But that normalization of the EEG must be accompanied by clinical normalization. She is responding. So there is an electro-clinical response to midazolam. If only the EEG improves, but the patient is becoming more obtunded, that is not an that's not a response. So that's what it is. Now when you say subtle clinical seizures, now you see that this is an autoimmune encephalitis girl, and you see that all that, intermittently, her eyes will open and the eyes will drift a little bit, and there may be some minor, very, very minor. You can see that it is. Yeah, so just very subtle, very, very subtle. And you see that now this is her background which is going on. Now you see how it evolves. Yeah, that is a starting point. You see, there is a rhythmic activity which is more than 2.5 hertz. And you can see that it is located in the left posterior head region. And then you see there is an evolution in frequency as well as location. It's becoming faster. It's becoming higher amplitude. And then again it decrements. So incremental response, then maintenance, and then decremental response. It took about 180 seconds. And then it goes off. So that's what it is. So it is an electrographic seizure, but that was accompanied by some subtle changes in the eyes. So that's what it is. So this is a classical electrographic seizure, right? There is a change, fluctuation in evolution, location, and frequency. That's what is important. Now, the last two components of this acute. This is a brief ictal rhythmic discharge. That is what is called BIRDS. Brief ictal, potentially ictal. It's not ictal. Because, why? Because, why is it called potentially ictal? Because by definition, electrographic seizure should last how many seconds? 10 seconds. So anything less than 10 seconds. Anything less than 10 seconds, 9.9 seconds, if it lasts, that means it is potentially ictal. If it stops short at less than 10 seconds, it is only potentially ictal. And the other criterion is that it should be at least more than 4 hertz. 4 hertz. That means 4 cycles per second, minimum. And it should last more than half a second, 0.5 seconds. From 0.5 seconds to 9.9 seconds, more than 4 hertz. So remember this, more than 4 hertz, more than 0.5 seconds, but less than 10 seconds. That is called brief, potentially ictal rhythmic discharge. That is it. So this is how, so that is a evolving. You can see that why it's called an evolving bird is because you can see that it evolves in both in frequency as well as in amplitude. So that's what it is. So that's Yeah, so these are some of the examples, and it can mimic the interictal discharge. So these are all called definite birds. Yeah, that's what it is. So rhythmic discharges. Again, rhythmic discharges. Now that's a good example of a bird. You see, it is more than 4 hertz, more than half a second, and it is located, it can be focal, it can be diffuse, but this is focal. It's in the occipital region, right? And it is in the same location as the interictal discharge. You can see the interictal spikes are there. In that same region, you have suddenly fast spikes, more than 4 hertz, and definitely more than half a second. So 0.5 seconds. That it fulfills the criteria for brief, potentially ictal rhythmic discharge. You'll see the next one. Again, the same thing, a little bit faster. Again, lasting for more than 0.5 seconds. So this is about a second, more than 4 hertz. And you see, this is the interictal discharge. Now you see that it is evolving. It's a definite bird because it is lasting now 3 seconds. It is less than electrographic seizure, and it's more than 4 hertz, right? So that's a very nice one. Again, there are 2 birds here. You can see that this is one bird, this is another bird. And then you see the bird, which is potentially ictal, becomes actually ictal. So that is what happens. You see this? Now it starts off there and continues and then evolves into a seizure from the same location. Now it has changed. So the bird has got, that's why it's called potentially ictal. Because if you record long enough, sometimes you will get a bird which is getting evolved into a seizure. Finally, the last one is what is called, I'll simplify it for you because this is called interictal ictal continuum. Why it is important is because, okay, we said that to call it a electrographic seizure. Electrographic seizure, what are the criteria? 10 seconds. More than, 25 discharges in those 10 seconds, correct? That is electrographic seizure. Now, what happens if it is lasting 10 seconds, right? But it is slower than 2.5 hertz. That means less than 25. Less than 25 in 10 seconds. That is what it is. See, this is a GPD because this is generalized, but it is less than 2.5 hertz. Got it? Right? So, this is not electrographic seizure. That is not electrographic seizure. So, you don't know what, so it is if it is electrographic seizure, you are going to treat it. But this one, no, you're not very sure. It doesn't fulfill the criteria for electrographic seizure, but it is frequent enough. So it is more than 1 hertz, but less than 2.5 hertz. That is the gray zone. The patient may be obtunded. You do not know whether to treat or not. That is called interictal ictal continuum. So you can see that this is a GPD at 1 hertz, and it's fluctuating between 1 and 2 hertz. Then the next it can progress on to become more than 2.5 hertz. So this is 10 seconds page. So it fulfills for one part of the electrographic seizure. But what it does not fulfill is, it is less than 2.5 hertz. But it is more than 1 hertz. That is what is called interictal ictal continuum. You're not sure it could continue into ictus from interictal state. And so that's a very confusing, whether to treat this person or not, that is up to an individual in each individual case. So thank you very much. I think I've tried to simplify it as much as possible.
So that was the last talk, but the most informative talk on ICU EEGs. So now we'll have EEG report and then EEG quiz. Sir has covered theory as well as practical part, shown all the varieties of EEGs of ICU. So before inviting KR sir for the next talk, may I invite Lakshmi for, because he is leaving to just collect his delegate kit. KR sir, please honor him for, yeah. This side should be okay. The photographer is on that side, so you can stand here. So, yeah, yeah, yeah. So one is delegate kit and one is faculty kit, sir. Both.